Hi, I'm Dr. Andrew Neviaser with OrthoVirginia, and thank you for joining us for our Facebook Live. For those of you who don't know about OrthoVirginia, we're one of the largest multi-specialty groups in the United States and the largest in the state of Virginia. We have people who specialize in surgery done all over the body. I personally specialize in shoulder and elbow surgery, and that's going to be the subject of my talk today. If you'd like to know more about our group, please visit OrthoVirginia.com, and you'll learn everything that you need to know. I chose to talk about options for rotator cuff management for several reasons. The most compelling reason is it is the most common source of pain in the shoulder. About 7 out of every 10 patients who walk into my office with shoulder pain have an issue with their rotator cuff. It's also a area of research focus for me, and for several years I led a task force for the American Shoulder and Elbow Society, helping decide what treatment recommendations we should give our patients for this problem. I chose this, however, for a more personal reason, and that is I think there is an enormous amount of misinformation about this topic out there. There are more wives' tales about the rotator cuff than any other problem in orthopedics, and I hope today I can dispel some of those. So I want to start talking about what the rotator cuff is. And it is a group of muscles and tendons that helps you raise your arm up above the level of your shoulder. It does rotate your arm, but in reality, its main job is to hold the ball down against the socket so the big muscle on the outside of your shoulder can actually do the lifting. And rotator cuff problems and rotator cuff issues are almost ubiquitous. Most people will experience some period of shoulder pain during their lifetime, and the vast majority of those will come after no injury at all. Rotator cuff tearing can come up in two ways. The most obvious ways are when people have frank injuries. You fall down the stairs, you have an accident, and you rip the tendon just like any other tendon in the body. But that only constitutes about 10% of the rotator cuff problems that we see. A much more common presentation is someone comes to the office with just the gradual onset of pain. And they're very surprised when they find out that they have a rotator cuff tear because they didn't injure it. And in fact, what's been happening in those scenarios is gradual wear and tear of the tendon that starts as early as when you are in your 20s, builds up over time, and ultimately leads to breakdown of the tendon where you get an actual hole. Sometimes that causes pain. Many times that doesn't cause pain. But when it does cause pain, it's built up enough so that the mechanics of your shoulder are thrown off. The rotator cuff doesn't do its job very well, and then it begins to cause the tendons themselves to get pinched when you raise your shoulder up, and often causes pain at night or when you raise your arm up above the level of your shoulder. I think that there are lots and lots of misconceptions out there about how to treat this problem. And it is one of the best studied problems that we deal with in orthopedic surgery. Even though the tendons break down and eventually you can get a hole in your tendon, it is very clear that most of these can be treated without doing an operation to repair that tear. In fact, over 80% of people who come into the office and begin to have pain can get better, whether they have a tear or not, with just doing some physical therapy exercises to correct the mechanics of the shoulder, and that gets the pain to go away. I'm often asked if that creates a problem of a bigger tear later in your life. Are we just kicking the can down the road? And the answer is sometimes, but it is very uncommon that once we get your pain better, further intervention like surgery is needed. And what I'm explaining to you is a process that is very well investigated. For a long time, we shared that concern that if we didn't go in and repair all the rotator cuffs that we saw that were torn, we would be facing patients with greater problems later in their life. And a very prominent research group that I am fortunate to be a part of did a study where they looked at almost 500 patients who had torn rotator cuffs treated with physical therapy. And we've now followed those patients out for more than 10 years. And what we have found is that very few have ultimately had to have surgery. In fact, most of them who were initially treated with physical therapy, who later chose to have surgery, did so in the very first few months of their treatment. And it wasn't because they were worsening, it was because they didn't think therapy would work for them. In the patients who were confident that therapy would work, very few have gone on to have surgery later. And what we have shown is that basically, if we can improve the mechanics, even with the torn rotator cuff, your shoulder can work just fine for the rest of your life. That is often frightening for patients because they recognize that they have a torn tendon and they expect that we'll say that they need to have it fixed. But I think what people don't realize is this is such a ubiquitous condition. It's very likely that even in the other shoulder where patients don't have pain, it is equally likely that they have a torn tendon. And in fact, if you just pull patients off the street and throw them in an MRI machine, by the time you get to the age of 40, there's about a 40% chance that we will find some tearing in your rotator cuff, whether you have pain or not. And it gets to about 50% when you're in your 50s. And by the time you get to 70, it's more likely that you have a torn rotator cuff than you don't, just based on pain alone. Now, we certainly do surgery for torn rotator cuffs. It's the most common shoulder surgery that we do because not everyone can improve with physical therapy. But usually after a trial of physical therapy has failed, surgery is the answer. And just as there's a wide spectrum of problems in people's rotator cuffs, there is a wide spectrum of surgery to treat those problems. For smaller tears in patients that are healthy, that have a good capacity to heal, and age plays a part in that, we do rotator cuff repairs. Those are traditionally done just through a little camera. We can now do it through 4 little poke holes, and we stitch your tendon back to the bone where it's supposed to be. Sometimes the tears are so large and they show us features on an MRI that suggest they can't heal. Sometimes we have to do shoulder replacements for those. And then there are a lot of operations in between. Sometimes we move tendons around in the shoulder to restore function. And those are decisions that we make based on characteristics of the particular patient and characteristics of the particular tear. But I think that it's important to recognize that this is a condition that is very, very common, that patients typically don't have an injury to get it, and that it doesn't necessarily require surgery. A few other things. There are a number of other conditions in the shoulder that present themselves in a very similar fashion as rotator cuff issues. So it's important that as a physician, we do a comprehensive examination of the shoulder, check how much motion they have, and patients are always surprised that an X-ray is a critical part of the evaluation because it's very difficult to figure out the true pathology behind shoulder pain without knowing that you aren't dealing with something like arthritis and some other issues like calcium deposits in the tendon. All of those will appear on X-ray. I am frequently asked about the X-ray because patients will tell me that they don't feel that they have a bone problem. And it's often surprising to them how much information we get about things that are not bones when they come in to see us and we ask for an X-ray. Just looking at the alignment between the ball and the socket can give us some insight into the integrity of the rotator cuff. As the rotator cuff begins to break down, the ball will shift relative to the socket. Sometimes that can be an indication that they have a tear even before we get an MRI. MRI in the United States is the gold standard, and we typically get that, usually for planning our surgeries, occasionally to evaluate the extent of the problem. This is an area where we haven't developed a definitive plan that is applicable to everyone. And it's important for you and your treating physician to sit down and discuss how this affects your life, what other medical problems are contributing to it, and the specific type of rotator cuff issue that you have. Most people are surprised to learn that their tendency to get this problem is also predetermined. It's not from playing too much tennis when they were young or playing rugby. Those things can contribute, but it's increasingly evident that this is a condition that is at least in part influenced by your genetics. And if you walk into my office with an MRI that shows a rotator cuff tear, it's about 4 times more likely I can find someone in your family that has a torn rotator cuff than if we just look at someone who's not related to you. So in many ways, although this is often described as a wear and tear phenomenon, it's probably not just that. It is a genetic phenomenon that is somewhat influenced by your environment, but your tendency to get this problem is probably predetermined. It's yet another thing you can blame on your parents. And so I think people have come in with a lot of worry about their rotator cuff, they're particularly when the MRI reports that it's torn. I spend most of my time reassuring people that that does not mean that they necessarily have to have surgery, more so than suggesting they do surgery for it, because those two treatments are essentially entirely equivalent, even in the long run. And I think it's important to recognize that you have choices. And the particular choice for you is very dependent on things that you may not be considering. Your life, the needs, the function of your arm, and whether or not you can commit to doing things like therapy versus surgery. And it's a topic that is being extensively studied even as we speak. Here at OrthoVirginia, we are in the next couple of months going to be opening a clinical trial where we are comparing surgery and non-surgical outcomes. And if you have some interest in enrolling in that, you can contact my office to see. Hopefully that will be up and running in the next couple of months, but it's something that I've participated in the past and hope to do so in the future. We're also likely going to be looking into some of the genetics of this problem because the exact gene sequences and things are still being worked out. But it's a fascinating area to treat, and it's a super common problem. And there's a lot of information out there that is less than accurate. And I think we at OrthoVirginia are trying to establish and contribute to formulating evidence-based practices that will provide the optimal treatment for our patients, whether that be surgery or therapy, because both are very valid treatments. I don't want to go on too long because hopefully there are some questions, and I don't want to get too deep into the weeds of the details of the research, but just know that it's ongoing. There's a lot already out there to help guide us, and there is some opportunity to participate in more if people are interested.
Thank you so much. Yes, we do have a bunch of questions coming in. So our first question is someone asking if they can increase the tear by daily activities.
So what I will tell you is that there is a tendency for tears to increase in size over time. Once you get to a true hole in your tendon, there's about a 60% chance that grows. So it's more likely than not, but not by much. And it's not clear that is dependent upon activity. It's more likely that is dependent on your genetic makeup. And so in general, I don't restrict people's activities who have these tears and tell them that they have to give up things in their life so that the tear doesn't get bigger. likely a predetermined scenario where the tear is either going to progress or it's not, no matter what they do.
Thank you. Do cortisone shots help?
What's that? Can you repeat that?
Do cortisone shots help?
So we have used cortisone shots for decades in orthopedics because they help eliminate the inflammation associated with injuries. And it's an interesting question, and I'm gonna pretend I'm an attorney and say it depends on your definition of help. There is evidence that they will give you short-term pain relief. They will do nothing in terms of healing your tear, and they have no clear proven benefit in the long run. We still do use them, although less than we used to, because what we're finding is that there is some potential detrimental effect on the tendon, on the bone, and newer evidence is suggesting that there is an increased likelihood of having a problem if you have surgery that correlates to the number of cortisone shots that you have. So if you've gotten a lot, you're more likely to get an infection if you ultimately have to get surgery. What I typically tell my patients is that if they're having difficulty with therapy and it's a struggle just to get through the exercises, or they're being awakened at night, which is a very, very common complaint in this condition, one cortisone shot is reasonable to consider, but we will get into trouble if we continue to do it. And in reality, one shot is typically the first shot gives you the best pain relief, and then every subsequent shot gets diminishing returns. So if one gets you a good long time, then once in a while I'll consider a second, but usually it's one and that's it. And I use one much more sparingly than I even did in my own practice as much as 10 years ago. So they are out there. There's all sorts of types of shots that we are investigating as an adjunct to the therapy, and I'm sure there'll be some questions about those. None has yet to be proven to be universally effective. I'm sure we'll get some questions about the use of what are called biologics, or taking healing factors and injecting them into these areas where you're having tendon breakdown to see if they can reverse the process. As we sit today, there isn't compelling evidence that we can, in fact, reverse the process, although there is some growing evidence that they can be helpful in other ways, reducing inflammation and things. And we're still working out the details of what biologics to use. Stem cells is a common question for me. And right now, we're not having the success with stem cells in this area that we anticipated. Stem cells seem to be morphing to the environment in the shoulder, which is one of breakdown, rather than changing that environment to one of building up. Things like platelet-rich plasma are showing some promise, and we're investigating those here at OrthoVirginia too. And they may not be working in exactly the fashion that we hoped, but they are showing some improvement in pain and some other things. So there's, again, lots of opportunities for us to make progress here and some experimental treatments. But in general, cortisone shots have a very limited role. But there are some what are called biologics that are probably going to play an increasing role as we go forward.
Thank you. And yes, you went ahead and answered the questions that were coming in about PRP and stem cells.
Yeah.
Our next question is, if someone is on a blood thinner and has torn rotator cuffs, does that affect what treatments they can have?
Usually it doesn't affect the actual treatment. Sometimes we have to work around the use of blood thinners. Let's say they have I should emphasize the distinction between the two types of rotator cuff problems. If you have a good shoulder one day and then you have an accident and you have a bad shoulder the next because you've torn your rotator cuff, we are much more aggressive with that type of scenario. We tend to do surgery for that. And if you're on blood thinners, what we typically do is put you out either on an alternative blood thinner or stop your blood thinner so you can get your surgery and then put you on afterwards. And that's just a matter of logistics. It doesn't alter the treatment. If we're not going to do surgery, there really isn't a downside to being on a blood thinner and having a torn rotator cuff. Those two don't interact significantly.
Thank you. Do torn rotator cuffs heal enough to allow for weight training?
So this is the moment that scares everyone when I tell them their rotator cuff will never heal unless we do surgery. Your body doesn't naturally heal a torn rotator cuff. And when we send you to physical therapy, our expectation is not that your pain goes away because the tear itself heals. What we do is we alter the mechanics of your shoulder, optimize the function of the other muscles in the shoulder that do the same job as the rotator cuff, and get you a pain-free and fully functional shoulder. And that often makes people nervous because they think we're asking them to accept a shoulder that isn't perfect. But in reality, there is an enormous amount of overlapping function between particularly the most commonly torn rotator cuff muscles and other muscles of the shoulder, so that you can have a shoulder that works perfectly well, where you appreciate no deficit at all and actually have a pretty sizable tearing of your rotator cuff. Because there's 4 of them, there's 4 muscles and tendons, and they have overlapping function. If you lose about 1.5 to 2, you can still have good function, and they can do the job of all 4. So part of why people develop pain and why ultimately sometimes we do surgery depends on which are torn, where they're torn, and how the other muscles are responding. And one of the reasons there's such a distinct difference in how we treat, say, traumatic tears, ones where your shoulder goes from very good to very bad very quickly, is because those shoulders have not had the time to gradually compensate for the torn tendon. Whereas if you have one that builds up over time, and these tears are almost like what you get when you wash your favorite jeans too much. The edge of the material begins to fray and then becomes a small hole, and then over time it becomes a big hole. That's exactly what happens to your tendon. So first we see fraying, then we see a small hole, and gradually it gets bigger. Over that period of time, your shoulder can compensate. Other muscles can take up some of the function that the torn one typically does, and then your shoulder will function totally normally. And so just a little bit of tweak of the mechanics that we can achieve through physical therapy usually gets you a pain-free and fully functional shoulder. And if you can achieve that, there's really no reason to go in and fix the rotator cuff. Our fear that it was going to lead to larger problems later is not turning out to be the case.
Thank you. You mentioned earlier that the gradual wear and tear of the rotator cuff can start as early as someone's 20s. Is there anything that a person can do when they are young so they can help try and keep that wear and tear from getting worse and causing a problem?
Change your parents. No, in reality, this is something that we're studying. And what I will tell you is that it's somewhat counterintuitive to tell you that a wear and tear problem will probably benefit from exercise. But the most compelling evidence I have to answer that question comes from our analysis of lab rats. And what we have found is that we can create a scenario similar to a rotator cuff tear. If we put a lab rat on a tiny little treadmill and we run them at very high cycles, so they're really working hard, and ultimately their leg tendons, because they don't really have the same shoulders that we do, they start to break down. But if we ramp those cycles back to a lower level, still exercising them, but not quite as vigorously, we actually see the opposite response, that they begin to show signs of better ability to improve repair of what we call that micro damage, or the early wear and tear and fraying. And so Exercising is probably beneficial as long as it's not done to excess. And so that it's difficult to translate what is excess for a lab rat to a human. But generally, if you are getting pain into the following day after you exercise, you're probably doing a bit too much. Is a kind of a practical assessment of what you do. But exercising is clearly helpful. There are some other interesting studies that have identified factors in us and in our lifestyles that may contribute to rotator cuff problems, like people who have high cholesterol are more likely to have rotator cuff problems. And that's something that is, I think, a little bit surprising, and we're still working on why that would be. But we can create models of rotator cuff problems by creating lab rats with very high cholesterol, among other things. So it's a complex issue that is not entirely under your control. And I don't think that there is evidence to tell people not to exercise, not to live the life they want. They should try to live the life they want, stay active, and likely that's the best way to keep healthy tendons. And if you have a problem, then we can address it.
Thank you. What is the typical recovery time after a rotator cuff surgery?
So that's a broad question. And recovery is something that needs to be defined. I try to emphasize to my patients that what they want to know are a couple of things. First, what they want to know is, when are they going to be happy that they did their surgery? When are they better than when they came to see me? And that varies, but certainly most people feel like they have improved function and diminished pain in the first probably 3 months after their surgery. But it's very, very clear that any surgery we do in the shoulder, whether it's big, small, or in between, if we put you through careful testing, like we do when we do research, we see improvements in your shoulder for as much as 12 months afterwards. But when we ask patients, when did you feel fully recovered, the most common answer is around 6 months. So improved by 3 months, you feel fully recovered by 6 months, you're actually fully recovered well after that. And there's some suggestion that it might be as much as 2 years that you continue to get benefit. But those changes happen slowly, and most people don't recognize that they're happening. If I develop a new technique for surgery and I want to publish the results of that technique in one of our medical journals, they require me to follow my patients for as much as 2 years so that I have a comprehensive view of how well they've done. So it's longer than you expect, but the benefit of surgery comes sooner than when you're fully recovered.
Thank you. Is heat or ice better for treating rotator cuff pain?
So what you should know that the rotator cuff is buried under your deltoid muscle, the big one on the outside of your shoulder, which is often fairly thick. In general, it is still considered to be true that ice is better than heat in almost all scenarios. Heat increases blood flow and potentially inflammation. Ice, in theory, does the opposite. In reality, there's very little evidence that either one has a dramatic effect, but I always recommend ice.
Thank you so much. We are at time. If we did not have a chance to answer your questions, we will answer them in the comments later. Would you like to close?
Well, thank you all for attending, and I hope that you found this interesting. It's something that I have spent the last 20 years studying, and I hope I didn't bore you too much with the research. But it's a very, very common condition that we at OrthoVirginia are very capable of handling for you. We would love to take care of you if you are experiencing this, or if you have some questions about our research trials and things, please come and see us.